Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome to SummaryCast.
Today, we're revisiting a fundamental topic in radiology, the risk of cancer associated with diagnostic imaging. It's a conversation that's been ongoing for decades, but new evidence is bringing it into sharper focus.
Right. We're looking at an editorial from a 2025 issue of the Korean Journal of Radiology. It's titled, Cancer Risk Associated with Radiological Examinations, 2025 Updates.
And it serves as a powerful summary and a call to action, prompted by what it calls two landmark studies published recently in the New England Journal of Medicine and JAMA Internal Medicine.
Landmark is a strong word. What makes them stand out?
Scale and methodological rigor. They provide some of the most in-depth analyses to date on this issue, and the editorial argues they reveal increased cancer risks that require a careful balancing of diagnostic benefits against radiation risks.
Okay, let's get into the first one. What did it find?
This was the RIC study, which stands for Risk of Pediatric and Adolescent Cancer Associated with Medical Imaging. It was a massive undertaking. They tracked 3.7 million children born between 1996 and 2016 across 6 U.S. health systems and Ontario, Canada.
How long was the follow-up?
An average of 10.1 years. The goal was to directly assess the relationship between radiation exposure from medical imaging and subsequent cancer risk.
And they found a relationship.
A clear dose-response relationship. And what's really striking is the level of exposure they found to be associated with a measurable risk. The study reports that a bone marrow dose of just 15 to 30 milligrays was enough to show an increase.
Put that in practical terms. What kind of exam is that?
That's equivalent to about 1 or 2 head CT scans. So a very common procedure.
1 or 2 head CTs. And what was the quantifiable risk for, say, hematological malignancies?
The excess relative risk was calculated at 2.54 per 100 milligrays. To look at it another way, when comparing children who received about 30 milligrays to those with no exposure, the risk was 1.76 times higher.
Are there absolute numbers? Relative risk can sometimes sound more alarming than the baseline reality.
Fair point. The study addressed that. For children exposed to at least 30 milligrays, the average dose in that group was 57, the cumulative incidence of a hematologic malignancy by age 21 was 39.9 per 10,000 cases.
And how much of that is considered excess cancer?
That represents 25.6 excess cancers per 10,000 cases. Based on this, the study estimated that about 10.1% of all hematologic cancers in this cohort might be attributable to medical imaging radiation.
10%. That's not a trivial number.
Not at all. And the authors of the editorial highlight the strengths that make this finding so robust. Its massive scale, the individualized dose calculation for every single scan, and the rigorous methods they use to account for things like reverse causation, meaning ensuring the imaging wasn't done because the cancer was already suspected.
Okay, so that's the first landmark study focused on pediatrics. What about the second one?
The second study, published in JAMA Internal Medicine, took a different approach. Instead of tracking a cohort over time, it aimed to project the U.S. national cancer burden from CT scans.
A population-level model.
Exactly. They used detailed organ dose distributions from over 120,000 actual CT scans and then scaled those findings up to the 93 million CT scans that were performed in the U.S. in a single year, 2023.
93 million scans in 1 year. And the projection?
The model projected approximately 103,000 future lifetime cancers would result from that 1 year of CT scans.
Wow. 103,000. How does that compare to previous estimates? I feel like we've seen these kinds of projections before.
We have. A well-known study from 2007 projected about 29,000. So this new estimate is 3 to 4 times higher.
Why such a big jump? Just more CTs being done?
That's a big part of it. The paper notes a 30% increase in CT use is part of the story,
But it's also due to improved methodology. The new study specifically accounted for multi-phase protocols, which made up almost 29% of the exams, and used examination-level dose data instead of more general protocol-based estimates.
So it's a more accurate and more sobering picture.
Precisely. And if current practices persist, the study suggests that CT-related cancers could account for 5% of all new cancer diagnoses annually.
There seems to be a paradox here. The first study highlighted that the per-scan risk is highest in children. So are most of these 103,000 projected cancers in kids?
It's a great question, and the data is surprising. The answer is no. Higher CT utilization in adults completely flips the numbers. The projection was 93,000 cancers in adults versus 9,700 in children.
So 91% of the projected cancer burden is in adults, simply because of the sheer volume of scans they receive.
That's right. It's a volume game. The paper also breaks it down by scan type. For adults, abdominal and pelvic CTs were the largest contributor, accounting for about 40% of the projected cancers. For children, it was head CTs, at 53%.
Got it. So we have two major North American studies. Are these findings outliers, or is this being seen elsewhere?
The editorial makes it clear this is not an isolated finding. It points to large-scale epidemiological studies outside North America that have yielded very similar results.
Such as?
There's the EPI-CT cohort study in Europe, which included about 950,000 individuals across 9 countries. It found comparable excess relative risks for both hematological malignancies and brain cancers.
Okay.
Then there are studies from South Korea. One found that children who had a brain CT from minor head trauma with a mean bone marrow dose of just 4.7 milligrays still had a 29% elevated risk of hematological malignancies.
Even at that very low dose?
Yes. And another Korean study looking at patients with appendicitis found that abdominopelvic CT was associated with an increased risk of these malignancies, and that the risk was markedly higher in children.
And this all points to a consistent dose-response relationship.
It does. The editorial mentions a meta-analysis of 26 studies that confirmed a linear dose-response relationship. It even noted that the cancer risk seen with this low-dose radiation was statistically compatible with the risk observed among atomic bomb survivors, which is a foundational data set in radiation biology.
Okay, the evidence seems robust and consistent across multiple large-scale studies. This brings us to the core of the editorial, the implications for practice. What's the takeaway here?
The main message isn't to restrict appropriate imaging, it's to eliminate unjustified examinations that expose patients to risk without a clear diagnostic benefit.
The focus is on justification. It always comes back to that.
It has to, especially for CT, which the editorial notes contributes to over 60% of the collective radiation dose for medical imaging, despite accounting for only about 10% of global radiological exams.
So it punches way above its weight in terms of dose. You'd hope justification would be airtight then. Is it?
The data suggests it's not. The editorial cites a 7-country European audit that found nearly a quarter of CT referrals did not meet evidence-based guidelines. The rates of non-adherence ranged from 16 to 32%.
That's a wide range, but even the low end is concerning. Any data specific to pediatrics?
Yes, in pediatric emergency departments, it's estimated that 25 to 30% of CT scans from minor head injuries are unnecessary. This is despite having well-established clinical guidelines specifically designed to identify low-risk patients who can avoid imaging.
So the guidelines exist, but adherence is inconsistent. That's one part of the problem. What else?
The second major issue is protocol optimization. The editorial states that this area likely fares no better.
What are the common failure points there?
Several are listed. Many institutions still use adult protocols for children, even though modern scanners have pediatric-specific protocols. Another is the overuse of unindicated multi-phase protocols.
How common is that?
The editorial cites a 2011 study which found that 53% of abdominal CT scans included at least one unindicated phase.
More than half. Yikes. That's a significant source of unnecessary radiation.
It is. And beyond that, dose-saving techniques are applied inconsistently, and regular dose monitoring remains uncommon in many places. It's a multifaceted problem.
Which suggests the solution has to be multifaceted as well. The editorial says the radiology community has long emphasized education on radiation safety, but it seems to be arguing that's not enough.
Exactly. The argument is that addressing these deep-seated barriers requires more than just telling people to do better. It requires system-level interventions.
Okay, let's walk through those. What's at the top of the list?
Integrating clinical decision support, or CDS, tools directly into referral workflows. The idea is to guide appropriate use at the point of care, before the order is even placed.
The classic CDS argument. The challenge is always getting people to use them without it feeling like just another bureaucratic hurdle.
True. The editorial acknowledges this and suggests that applying artificial intelligence to this process might improve compliance without disrupting workflow as much.
What's next?
Promoting alternative modalities, making options like ultrasonography and magnetic resonance imaging practically accessible, not just theoretically available. This is especially critical for children.
Practical accessibility is key. It doesn't matter if MRI is a better option if the patient can't get an appointment for 3 weeks.
Precisely. And then for when imaging is indicated, there's the optimization piece. Standardizing protocols is a huge one. It can reduce both the radiation dose and the variation between scans.
And within that, a few obvious steps.
Yes, the use of pediatric-specific protocols that incorporate dose-saving techniques, and making single-phase CT the default modality with multi-phase protocols reserved only for clear indications.
Seems straightforward enough. How do you ensure it happens?
With audits. Regular audits of adherence to both appropriateness criteria and dose optimization standards to make sure safety protocols are actually being maintained.
So we have better tools, better protocols, and better oversight. That covers the clinical workflow, but the editorial goes broader, doesn't it?
It does. It moves beyond individual practices to the system itself. One of the biggest points is about reimbursement models.
Let me guess. They need to prioritize appropriateness over volume.
You nailed it. The editorial argues that as long as the financial incentives reward doing more scans, it will be an uphill battle to reduce unnecessary imaging. Fee-for-service is explicitly called out as rewarding volume.
That's a fundamental misalignment of incentives. It's a much harder problem to solve than, say, updating a protocol.
It is. And it ties into the final overarching point. Building a culture of radiation safety. The editorial stresses that this has to be a core institutional priority and a quality measure for healthcare systems.
And not just the responsibility of the radiology department.
No, it has to be broadly shared among radiologists, referring physicians, technologists, administrators, everyone. That's what's needed to sustain progress.
So, to land this, let's summarize the bottom line. What's the main takeaway from this 2025 update?
I think it's that the evidence for a real, quantifiable cancer risk from CT is now stronger and more precise than ever before, thanks to these massive, well-designed studies. The numbers are not vague estimates anymore. They are concrete projections based on enormous data sets.
And because the evidence is clearer, the call to action is more urgent. The problem isn't the technology itself, but its application. Specifically, the significant number of scans that are either not justified in the first place or not optimized for dose.
Exactly. And the solutions presented are not about individual blame, but about systemic change. It's about building better workflows with decision support, optimizing protocols, changing financial incentives, and fostering a shared safety culture.
The goal remains unchanged. Maximizing the immense diagnostic benefit of these technologies while being absolutely rigorous about minimizing the risks. This editorial crystallizes the current state of that challenge.
A well-put summary. It's a reminder that justification and optimization are not just best practices, but essential components of patient safety.
That's all for this episode of SummaryCast.